متشكرين جدا دكتور محمد سرحان على ال very informative lecture you have given us. دكتور محمد كتر خيرك. ويسعدني دلوقتي ان انا اقدم لكم الدكتور محمد الطواوي العطيوي العطيوي جامعة سوهاج، هيكلمنا على Arthroscopic Subtalar Joint Fusion. طيب تمام يا دكتور محمد، ما انت قريبنا اهو. تمام، امتعنا بقى.
بداية حابب أشكر اللجنة المنظمة على المؤتمر بقيادة الأستاذ الدكتور سيد عبد الحميد والدكتور حمدي تمام. وكويس إن أنا شفت الكثير من الزملاء على رأسهم الدكتور محمود أبو المجد اللي كان في أمريكا ولسه واصل حالا من كام شهر، الدكتور عماد حمدي وزميلي وصديقي الدكتور أحمد خير. Arthroscopic Subtalar Joint Fusion, a minimal invasive approach to subtalar arthrodesis, indication, technique, and outcome. Isolated subtalar arthritis. The main cause of subtalar arthritis, all of us know that it is the most common cause is trauma, either calcaneal fractures or lateral fractures in Hawking type 2. It may be occur in primary talocalcaneal arthritis, either instability or due deformity, either in residual cases of talocalcaneal coalition. Also in case of posterior tibial tendon dysfunction in stage 3, nowadays we are calling it progressive collapsing foot deformity. Also, it may occur in case of inflammatory arthritis when it is isolated to subtalar in case of rheumatoid or seronegative. Non-operative management is the first line of therapy, but surgical intervention is reserved to the refractory cases. What is the non-operative management? We start with weight loss, activity modifications, comfort shoes and bracing, and sometimes we give the patient non-steroidal, or also sometimes we give injections in the form of corticosteroid injection. If all these conservative method fail to treat, we will go for operative treatment. The main treatment is arthrodesis. There are two types of arthrodesis, either open technique or arthroscopic technique. The open technique is the traditional approach which, with direct visualization and may include bone grafting. There are two types of open approach, either sinus tarsi approach or the extended lateral approach. Nowadays, there are the arthroscopic assisted technique, which is minimally invasive, and this is reducing soft tissue morbidity and faster recovery. Why arthroscopic? The evidence base. About 17% have a complication rate in open in the form of wound healing problems and nerve injury. And also 55 to 90% only have a fusion rate. Hind-foot arthroscopy has emerged as a reliable diagnostic and therapeutic tools. Arthroscopic subtalar arthrodesis was developed to reduce surgical morbidity, facilitate earlier rehabilitation, and minimize wound complication associated with open arthrodesis. في phase 1, the lateral approach, but nowadays go to phase 2 is the posterior approach when the patient lie in prone position. What is the surgical instrument and implant we are needed in this maneuver? First of all, we need 4 mm and 30-degree arthroscopic camera with video towers. For joint preparation, we need motorized shapers, bare, curette, and osteotomes. Also, we need a fluoroscopy, imaging intensifier, C-arm, and for fixation, we need 6.5 or 7.3 cannulated screw, or sometimes we use double compression screws. Anesthesia and patient positioning. Preoperative setup, we give the patient intravenous antibiotic within 1 hour of incision. Me use general anesthesia or spinal anesthesia, but in most of cases we use spinal anesthesia. Thigh tourniquet applied for bloodless field. The position, the patient will put in prone position on the operating table. This position facilitating posterior portal access and optimal arthroscopic visualization of the subtalar joint. The main part of the subtalar joint we prepare is the posterior part. What are the portals for this maneuver? There are two main portals. The first is the posterolateral and the posteromedial. What is the anatomical landmark? The anatomical landmark is the lower part of the fibula. We took a line parallel to the sole. On each side of the tendo Achilles, on the medial and the lateral, just above this line is the portal. On the lateral side is the posterolateral, and in the medial side is the posteromedial. We all of us notice that the fibula is much more lower than the medial malleus. Exploration and joint surface preparation. Identification of the joint line starting on the posterolateral portal. The posterolateral portal is the first portal, which was performed with a skin incision and blunt dissection of the subcutaneous tissue with a mosquito clamp or trocar directed towards the big toe. Then posteromedial portals was performed. This is the posterolateral and this is the posteromedial. This is the sheaver. This is the camera. The most important anatomical landmark is the FHL, the flexor hallucis longus tendon. Beyond this medially is the neurovascular bundle. This tendon was easier to visualize after first identification the belly of the muscle, just immediately proximal to the posterior terar process. This is the talus, this is the calcaneus, this is the FHL. The cartilage was resected by alternating between blades, burr, curette, chisel, and the entire posterior subtalar surface is progressively visualized in a posterior to anterior direction. Till what? Till the interosseous talocalcaneal ligament. Interosseous talocalcaneal ligament. This is the anterior boundaries for this maneuver. How to fix? After preparation, how to fix? Fixation was achieved with two cannulated screws, either 6.5 or 7.3, inserted into the calcaneus and the talus in neutral position or 5-degree valgus. Two pins were inserted into calcaneal tuberosity in an upward and anterior direction to the superior surface of the calcaneus and talus under fluoroscopic guidance. Like this. The goal was to obtain a direction perpendicular to the posterior subtalar surface in order to maximize the compressive forces. The position of the arthrodesis pin is checked in the anteroposterior and the lateral fluoroscopy. Then cannulated screw, or sometimes we use double compression screw, inserted to apply compression to the subtalar joint line, like this. Post-operative protocol. The patient is immobilized and kept in non-weight bearing in a short leg splint. Then we are checking the wound at 7 and 40 days, then suture removed. Follow-up X-ray is done at 6 weeks, 3 months, and 6 months. First of all, there are limited weight bearing until the evidence of union following subtalar arthrodesis. Usually at 6 weeks of limited weight bearing, followed by 6 weeks of protected weight bearing in a cast or walking boat. If radiographic union is appreciated at 3 months, the patient is weaned out of walking boat and begin gentle range of motion exercise, and the patient could be returned to daily activity. This paper has been published in 2023, and the cases was post-traumatic subtalar joint arthrodesis. The study was a prospective case series study conducted on 20 patients suffering from post-traumatic subtalar joint arthritis. These 20 patients were managed by posterior arthroscopic fusion. The mean age was 33.25, ranging from 17 years to 55. 70% were male and 30% were female. 9 patients were suffering from subtalar arthritis in the left side and 11 in the right side. We notice that there are marked improvement in the American Orthopedic Foot and Ankle Society score from preoperative 36 to postoperative 83. The operative time, the mean operative time was 98.75, and the union reached in about 14.5. Take home message: arthroscopic subtalar arthrodesis produce high quality joint surface preparation and high fusion rate with little morbidity and rapid recovery. Thank you.